Hello, making practice for the Viva speaking skills of anesthesia exit exam in Pakistan. Okay, I'm starting the topic of anaphylaxis. The scenario is you are anesthetizing a young woman for hysteroscopy. Shortly following the injection of thiopentone, her blood pressure becomes unrecordable. She is flushed and her lungs are very difficult to ventilate with a bag and mask. What are your immediate actions? Okay, the examiner will ask the questions and I'll answer. You should be grinning inside your anaphylaxis drill. What is the drill? Stop administration of suspected agent. Number 2, maintain airway. Give 100% oxygen. Then lay the patient flat with feet elevated. Okay, if he is not anesthetized. What are the 3 steps? Stop administration. Number 200% oxygen. Lie flat. Give adrenaline. IM at a dose of 0.5 to 1 milligram. 1 milligram is 1 ampule of adrenaline. Repeated every 10 minutes if required. IM dose 0.5 to 1 mg. Direct if repeated every 10 minutes if required. And IV at a dose of 50 to 100 mics for hypotension or cardiovascular collapse, titrated up to 0.5 to 1 milligram as required. IV is 50 to 100 mics, titrate for hypotension or collapse, titrated up to 0.5 to 1 milligram as required. Or give IV fluids, crystallized vocaloids. Okay, this is the drill. Stop administering the causative agent, 100% oxygen, lie flat. Give adrenaline. IM dose is 0.5 to 1 milligram. IV dose is 50 to 100 mics, titrated up to 1.5 to 1 milligram according to the cardiovascular collapse. Give IV fluids. Acha, what secondary therapies would you administer or consider? Secondary therapies are antihistamines, chlorpheniramine 10 to 20 milligram by slow IV infusion, corticosteroids, hydrocortisone 200 mg, IV catecholamine infusion if poor response to initial bolus like norepinephrine. Then bronchodilators may be needed. Inhaler, salbutamol, by Ventolin. IS can be through ETT or puffs, or if patient is not anesthetized directly. And also IV bronchodilators. Consider bicarbonate 0.5 to 1 millimole per kg. Okay, antihistamine, corticosteroids. Whenever there is anaphylaxis, give other agents: antihistamine, corticosteroids, norepinephrine, vasopressor infusions if needed, bronchodilators, and bicarbonate. Antihistamines, corticosteroids, vasopressors, catecholamine infusion. So catecholamine means adrenaline infusion is anaphylaxis. How would you investigate this patient for suspected anaphylaxis? Investigation can be divided into immediate and late. The diagnosis of anaphylactic or anaphylactoid reaction hinges around the plasma tryptase concentration. The test is plasma tryptase concentration. Okay, the immediate and later investigations. In immediate investigations come identification of an anaphylactoid reaction. Take 10 ml venous blood into a plain tube to be spun down to separate the serum and store at -20 degrees C. Send to reference lab for tryptase estimation. Take several samples immediately if the clinical saturation allows. 1 hour after start of reaction, 6 to 24 hours after the reaction. Immediate sample, then 1 hour after, then 6 to 24 hours after. 3 samples for tryptase investigation, 10 ml of IV blood. The rise in tryptase is transient and so timing is important. Tryptase concentration is thought to reach a peak at 1 hour after an anaphylactic reaction, but there is evidence to suggest that the rise is earlier in reactions with hypotension. If the 1 hour sample only is taken, the rise may be missed. It is essential to label the samples with appropriate timings. Okay, tryptase 10 ml IV sample at 1 hour, then immediate, then 1 hour, then 6 to 24 hours, or 3 samples should be labeled with proper timings. Okay. And later investigations are identification of suspected agent. The patient should be referred to a regional allergy specialist. Skin prick tests Anesthetist is responsible for ensuring they are performed either by himself or ideally a specialist in interpretation of skin tests. Because the patient should be referred to the allergy center, the causative agent should be identified, and skin prick tests are done. Tell me about plasma tryptase if the examiner asks. Protein contained in mast cells, this tryptase. 99% of total body tryptase is within mast cells. Okay, released along with histamine and other amines in anaphylactic anaphylactoid reactions. It is contained in cells, mast cells 99%, and released with histamine and other amines in response to anaphylactic reaction. Sensitive and specific diagnostic test for anaphylactic anaphylactoid reactions. Half-life 2.5 hours. Basal level 0.8 to 1.5 nanogram per ml. I don't think so. This needs to be memorized. Level more than 20 nanogram per ml seen in anaphylactic reactions. Okay, urinary methylhistamine is the principal metabolite of histamine, but is difficult to interpret outside the normal range, although it will be detectable for longer than plasma tryptase. Okay, urinary methylhistamine is another test. How do you perform skin prick tests? Testing should occur 4 to 6 weeks after the reaction. Okay, this is the later test. Immediate is tryptase and later is skin prick test after 4 to 6 weeks after the reaction. Testing should include a wide range of anesthetic drugs as well as the suspected agents to establish those drugs that are safe for future dose. As a skin prick test, we test the range of anesthetic drugs, get that which was the agent that caused that drug, like the test dose. Performed with neat drug and 1 in 10 dilution. That should be a diluted one. Positive control histamine and negative control phenolsaline should be included for each test. A drop of drug is applied to the volar aspect of the forearm. I think this one, and a lancet stabbed. This is forearm, and a lancet stabbed through it to break the skin but not draw blood. Okay, subcutaneous. Sites are inspected over 15 minutes for wheal and flare. A wheal of more than 2 mm larger than the negative control is regarded as positive. A positive skin prick test to 1 in 10 solution is a true positive. Two reactions may have positive tests at much greater dilutions, e.g. 1 in 100 or 1 in 1000. That two will be positive in 1 in 100 and even 1 in 1000 dilutions. And the wheal more than 2 mm than control is considered positive. A positive test to need drug may or may not be significant. Okay, and how do we report to the patient? That give full explanation to the patient. Medical alert bracelet, give him a bracelet. Record in the case notes, explain to the patient, then record in the case notes, inform GP, complete a yellow card to notify the MHRA. Explain the patient, give him record in the case notes, give him a bracelet, inform the GP. Inform the GP is first. Okay.